Hi there, welcome to Doctor's Place Academy. This is me, Dr. Asya Zameer, and today's topic of interest is OPD case presentation of lung TB. Before jumping right toward the video, I would like to address that this video is divided into two parts. First one comprises of a general brief introduction of tuberculosis, and the next one its clinical correlation, that is in the form of OPD case presentation, of which you can clearly make an idea by reading the highlights of today's video. That after this video you will be able to define that what tuberculosis actually is, its related sign and symptoms, a general idea about pattern of history, how to confirm your diagnosis, and more toward some investigational approaches, and lastly the management. Now without wasting our time, let's jump onto the video. That what tuberculosis actually is, or its acronym TB. TB is basically infection of lung parenchyma, that is functional part of the lung, or can be defined as chronic granulomatous inflammation of lungs. The bug responsible for it is Mycobacterium tuberculosis, that is an acid-fast bacilli. There are multiple types of TB, but the main entity of this lecture is lung TB. The other ones, for the sake of information, are also enlisted. These are CNS TB, or to be specific, meningeal TB, kidney TB, abdominal TB, lumbar vertebral TB, also known as POTS disease. On the basis of cause or occurrence, the lung TB is further classified into primary and secondary TB. Primary TB is caused by direct invasion of the Mycobacterium tuberculosis on the first exposure, while the secondary TB is caused by reduced immunity of the host. Primary TB is usually asymptomatic, but a very small percentage of people get symptoms like flu-like illness, which is self-limited and vanishes on its own within a day or a week. The major concern of today's topic is secondary TB, that is an opportunistic infection and occurs to those who have reduced immunity, that is they are immunocompromised. And this immunocompromised state of human body causes the organism that was earlier latent or inactive to be activated. The symptoms of secondary tuberculosis include cough that is persistent in nature and persists for weeks or even the months, low grade fever, night sweats, weight loss. If not treated on time, complications could include bronchial asthma when it locally spreads to the nearby bronchioles, or systemic miliary TB when the infection spreads via circulation. The word miliary is a name of a particular seed, and hence systemic miliary TB means seeding of TB to the different body parts, which we have already named in the previous slide. This is a theoretical information regarding TB, now moving toward its clinical side. The information provided in this slide is arbitrary, just to give you an idea that whenever a patient comes to visit you, regardless of your specialty, you are obliged to ask for the demographic data of the patient. This include name of the patient, age, sex, occupation, address, and date of visit. Following this, you will ask the patient for the complaints that bothered him to leave his comfortable bed and has come to your clinic. The chief complaints of the patients are equivalent to the symptoms that I have discussed earlier, that the patient presented with a persistent cough for the past 2 months, which has worsened over the past 2 weeks. The cough is productive of sputum, which is yellowish green in color. The patient also reported having night sweats, weight loss, and fatigue. The productiveness of sputum and its yellowish green color are signs to direct you toward diagnosis of TB. Along with the chief complaints, you are obliged to ask for the past medical history, that if he had any chronic disease in the past, his family history, his social history, to make a clear cut idea for the diagnosis. After bearing the symptoms in mind, you will take consent for physical examination. As you can clearly see that this patient has all the vitals, that is blood pressure and saturation pressure of oxygen and so on in normal ranges. Further, you will go for the auscultation and palpation. On auscultation of the lungs, it reveals bilateral crepitations. Now, what are crepitations? Crepitation is a sound made by popping of gas bubbles. It is a crackling sound. By palpation of abdomen, you find hepatosplenomegaly, that is enlarged liver and spleen. On palpation of neck, you find swollen cervical lymph nodes, that is lymphadenopathy, or to be more specific, in cases of TB, is known as scrofula. To make your diagnosis more precise, we'll take some help by some investigational approaches. Chest X-ray and sputum CS test are both a great investigations to be done, while the PPD test, which is not recommended now, and the reason for its downfall are two, that it's inconvenient and non-reliable. It's inconvenient for the patient as it requires patient to be under observation for the next 72 hours, and non-reliable as it can give false negative results in cases where patient had received BCG vaccine and also cannot distinguish between active and latent infection. Chest X-ray findings are bilateral infiltrates. These infiltrates are actually hilar lymph nodes that have undergone caseating type of granulomatous inflammation followed by fibrosis, hence appear opaque on chest X-ray. In sputum CS test, sputum of the patient is sent to the lab for culture so that organism could be identified and sensitivity test for the commencement of antibacterial regimen. Another test which is not mentioned in the slide is IGRA, that is interferon gamma release assay. It is a more specific one and convenient to do so because it is a blood test, but the disadvantage is that it's pretty much expensive and a single test costs for around 12 to 13,000. Investigation weigh about 20% for any diagnosis to be done. Rest of it, that is 80%, depends upon patient's clinical history and physical examination. So you better know how to take history and do physical examination of the patient. Based on the patient's clinical history, physical examination, and investigation, the diagnosis of pulmonary tuberculosis is established. Now, on to the remedy for which the patient has seeked your attention. Management of patient is done not only by the use of medicine but also with your kind words. The course of therapy is 6 months for uncomplicated ones, but for complicated ones, for example, the tuberculosis is refractory to treatment, then we can protract the course up to 9 months. The patient is started on a 4-drug regimen of rifampin, isoniazid, pyrazinamide, and ethambutol for the first 2 months, that is intensive phase, followed by 2-drug regimen of rifampin and isoniazid for the next 4 months, that is continuation phase. The patient is advised to practice respiratory hygiene, including cough etiquette and wearing a mask to prevent the spread of disease. The patient is advised to complete the full course of treatment and follow up regularly for monitoring and management of adverse effects. You are also obliged to calm the patient down about the disease, that it's totally curable disease. You just have to complete your course and you will be absolutely fine then. The patient is also referred to the hospital's tuberculosis control program for contact tracing and management of the patient's family members and close contacts. The patient is advised to return to the clinic after 2 weeks to monitor the response to treatment and for the management of adverse effects. During the prescription of treatment, you have to tell the patient that after taking the drug, he might get dark or orange colored urine. He should not worry and do not discontinue the treatment. It is one of the side effects of the therapy. Thank you for watching this video and joining me at Doctor's Place Academy. I hope you found the information useful and informative. If you have any questions or feedback, please leave a comment below. And do not forget to subscribe our channel to stay up to date with the latest content. To seeing you in the next video. Up till then, Allah Hafiz.